To understand the threat of malaria, we have to start at the cellular level. When a single infected red blood cell latches onto the endothelial lining of a narrow blood vessel, it begins a pathogenic cascade that can eventually shut down entire organ systems. What begins as a microscopic, localized event rapidly multiplies, spreading millions of active parasites throughout the human cardiovascular system in a matter of days. This systemic invasion is initiated by a specific biological vector. As seen in this image of the female Anopheles mosquito, transmission occurs exactly when she feeds, directly injecting the parasite into the host's bloodstream. The severity of the resulting infection depends entirely on the species of Plasmodium injected. While Plasmodium vivax is known for causing relapsing fevers, Plasmodium falciparum is inherently more virulent. Left unchecked, a falciparum infection aggressively targets the microvasculature, leading directly to life-threatening clinical endpoints, like cerebral malaria and complete multi-organ failure. Effectively treating this infection requires clinicians to map pharmacological agents to the parasite's specific metabolic vulnerabilities at distinct life cycle stages. Mastering clinical management means mastering the exact intersection of parasite biology, systemic pathophysiology, and targeted chemistry. The infection cycle starts at point 0. The mosquito bite introduces the parasite in its infective stage, the sporozoite, straight into human circulation. This diagram maps the initial path of the sporozoites. They don't linger in the blood. They travel rapidly to the liver, where these glowing markers show them embedding directly into individual hepatocytes. Once inside, the standard hepatic replication process begins. The sporozoite multiplies into a structure called a schizont, eventually bursting the liver cell wall to release a massive swarm of new parasites, called myrizoites, back into the bloodstream. There is a critical biological exception to this standard cycle. When the infecting species is Plasmodium vivax or ovale, some parasites diverge from active replication. Instead, they form hypnozoites, dormant reservoirs hiding inside the liver tissues. Because these hypnozoites are metabolically inactive, they easily evade standard initial treatments. They can reactivate months later, causing clinical relapses long after the primary blood infection seems cleared. To eliminate this hidden threat, clinicians deploy a targeted pharmacological countermeasure, primaquine. This drug specifically attacks and clears the dormant liver stages. However, administering primaquine comes with a mandatory clinical prerequisite. Patients must be screened for G6PD enzyme deficiency because giving primaquine to a deficient patient triggers severe hemolytic anemia. Achieving a radical, permanent clinical cure requires addressing both the active blood infection and these invisible dormant liver reservoirs. When active myrizoids pour out of the liver, they violently invade passing red blood cells, initiating the clinical phase of the disease. Inside the red blood cell, the parasite systematically matures. It progresses from an initial ring form into an active trophozoite, and finally into a fully developed schizont. This peripheral blood smear captures the parasites mid-cycle. Identifying these specific intraerythrocytic stages, like the distinct purple ring structures visible inside the cells, remains the gold standard for clinical diagnosis. The pathogenesis peaks at a precise moment. This mechanical rupture ejects a new generation of merozoites alongside sharp geometric particles of toxic waste called hemozoin. The sudden dumping of parasitic debris and hemozoin into the bloodstream triggers an immediate immune response. The body releases massive amounts of pro-inflammatory cytokines, specifically TNF-alpha and interleukin-1. This sudden cytokine storm directly drives the patient's classic clinical triad, the abrupt onset of intermittent fever, severe rigors and chills, followed by a phase of profuse sweating as the fever breaks. Because the mechanical rupture of the red blood cells happens on a strict biological clock, the patient's fever spikes are highly predictable. Plasmodium falciparum and vivax rupture every 48 hours, causing tertian fever, while Plasmodium malariae takes 72 hours, resulting in quatern fever. Plasmodium falciparum presents an additional lethal trait. Infected red blood cells develop sticky surface proteins and undergo cytoadherence, cementing themselves to the endothelial walls of blood vessels and completely halting blood flow. This localized microvascular blockage starves downstream tissues of oxygen. When this occurs in the brain, it causes cerebral malaria. In the kidneys, it leads directly to acute kidney injury. A patient's physical symptoms, favor charts, and mortality risk are dictated by this synchronized biological clock and the surface mutations of the parasite. To stop this destruction, we have to look inside the parasite's internal digestive chamber, or food vacuole. This diagram outlines the historical baseline of treatment. The drug chloroquine enters the vacuole and physically blocks the parasite from detoxifying free heme. By jamming this metabolic pathway, chloroquine forces a lethal accumulation of toxic heme, poisoning the parasite from the inside out with its own metabolic waste. But evolutionary pressure forced an adaptation. The parasite developed the PFCRT efflux pump. This physical channel forcefully ejects chloroquine molecules back out of the vacuole before the drug can act. Because of this single structural mutation, chloroquine has been rendered largely ineffective against severe falciparum malaria worldwide. The modern pharmacological solution relies on the artemisinin class of drugs. This schematic shows the chemical structure of an artemisinin molecule, focusing specifically on its highly reactive center, the endoperoxide, or oxygen-oxygen bridge. This molecule acts as a targeted explosive. The reaction is triggered precisely when artemisinin encounters high concentrations of heme iron, Fe2+, inside the infected red blood cell. The iron chemically cleaves the endoperoxide bridge in half. This split releases a violent, rapidly expanding wave of highly reactive free radicals. These free radicals instantly attack the parasite's internal architecture, shredding vital proteins and destroying lipid membranes through direct chemical peroxidation. This blunt force chemical reaction reduces parasite biomass faster than any other known drug class, achieving incredibly rapid clinical clearance. Overcoming widespread genetic resistance required abandoning easily bypassed metabolic blockades and utilizing highly reactive chemical mechanisms to rapidly halt organ damage. The current standard of care for uncomplicated malaria is built around this rapid action. This table illustrates the WHO protocol, Artemisinin-based combination therapy, or ACT, which always pairs an artemisinin derivative with a secondary partner drug. Let's break down the logic. The artemisinin component acts as the primary strike force, driving a massive near-vertical drop in the parasite count. Its primary job is rapid knockdown, clearing up to 99% of the total parasite load within a matter of hours. The second half of the ACT regimen utilizes slower-acting partner drugs like lumefantrine or sulfadoxine pyrimethamine, taking over at the infection curve's bottom tail end. Having a longer half-life, they linger for days, eliminating the surviving 1% of parasites that weathered the initial assault. This two-stage architecture mathematically restricts the survival and propagation of resistant mutant strains, preserving the long-term efficacy of both drugs. For severe malaria, cases complicated by exceptionally high parasitemia or neurological involvement, the clinical protocol tightens further. In these life-threatening scenarios, oral combination therapies are bypassed entirely. Intravenous arsenate becomes the absolute drug of choice. IV arsenate achieves therapeutic blood concentrations faster than chloroquine and is uniquely effective across all blood stages, attacking early rings, trophozoites, and young gametocytes alike. As this image of the World Health Organization headquarters indicates, this specific IV protocol is the explicit, data-driven global recommendation for significantly reducing patient mortality. But clinical interventions only address the infected host. As seen with this insecticide-treated bednet, pharmacological cures must be paired with aggressive vector control to break the transmission cycle at its source. Ultimately, managing malaria requires a systemic approach. It relies on an architectural system of protocols that precisely matches multi-drug pharmacodynamics against the complex, highly adaptable biology of the parasite.